Hello there. Welcome to this afternoon session. I'm delighted to have Dr. Vivian Hall from Zita West Clinic on today. So hopefully she'll be joining us very soon. Great, people can see me. Okay, fantastic. So we've got lots and lots of questions to go through, and I'd love you to ask questions as we're doing this as well, which would be brilliant. Hi, Emma. So let's just see if Vivian is going to join us any minute now, and I'll have my questions ready for when she does. Okay. So hopefully she's joining us. Anyway, lots and lots of questions on natural IVF, on mild IVF, on low AMHs, which I'm hoping that Vivian will be able to answer, and also on vitamins and minerals and diet, etc. We had a great response on Monday with Isabel doing nutrition, which was really, really good. So we had a lot of questions from that. So let's just hope that Vivian is coming on now. I can't see any sign of her at all. So I'm going to start with some of the questions that I've been given. And I'll start with the nutritional ones so that when Vivian comes on, she'll be able to do some of the IVF ones. Oh, great. Here we are. Hopefully she'll be joining us any minute now. Let's just see. Great connection. Brilliant.
Hi.
Vivian.
Good. How are you?
How are you?
Good. How are you?
I'm fine, thank you. Lovely to see you. Thank you for doing this today. We've got lots and lots of questions. So how are things
All good,
at the clinic?
yes.
All good?
Very good. Yeah.
Seeing lots of clients and...
Yeah.
Brilliant. Brilliant. Okay, I'm going to start with some of the questions that have come through. So the first one is from a lady who's 40. What can I do? I'm 40 years old to improve my egg quality. Is it worth focusing on these changes for a few months, delaying my planned treatment, or should I just start a cycle? My background is I've had 5 rounds of medicated IUIs, which were unsuccessful. And I've had 2 FETs, frozen embryos transfers, which resulted in a chemical pregnancy and miscarriage.
Okay, that's we need some more information there. It depends how long ago those embryos were made, which were used in a frozen embryo replacement cycle. But basically, I'm sure this lady knows that the key thing at her age, at 40, in terms of quality, you see, there's genetic quality and biochemical quality, and the biochemical quality is what we really try to talk about when we talk about nutrition and lifestyle issues and that sort of thing. And I'm sure she is already doing everything she possibly can and taking supplements and avoiding too much alcohol and not smoking and that sort of thing. Unfortunately, there's nothing at all she can do with the genetic quality of the embryos, and that is the key factor at the age of 40. So
yeah, she's just replied here that the frozen embryos were made when
she was 38 when she made those embryos, and she's had 2 frozen embryo replacements, and they were both. And were the embryos tested?
She doesn't say that unless she gets back and says it. But you know, Vivian, I'm and I know you are as well with nutrition. I think she shouldn't put off doing her IVF cycle because of her age. We know that IUIs, the success rate aren't brilliant, are they? You know, it's sort of fine to do 1 or 2, but you can sometimes lose a lot of time by doing IUIs.
If I were to see this lady tomorrow in the clinic, I'd be saying to her, let's get on with it as soon as possible. I'm sure she's already got a very good diet and is looking after herself properly. And the key thing that's changing with her is her egg genetic quality is changing, you know, year by year, month by month. And so the sooner we start again, and I would highly recommend actually test if she gets a good number of embryos, if she responds well, if her egg number is good, and if her ovarian reserve is good, then it would be in her interest to test the embryos to see if they're genetic.
Yeah, she did. Yeah, she didn't have them tested last time. So I
Yeah.
would be telling her as well, vitamin D, inositol, CoQ10 for the mitochondria of the egg, doing everything she can, because I think that's important as well, that you feel like you're ticking all those boxes.
Absolutely, but don't
Yeah.
delay. Get on with it.
Okay. Next. Yeah, no, I agree. We are looking at changing fertility clinics. We only have one straw left of sperm, so obviously some issues with male fertility there. We are we are a same-sex couple. I have PCO and a higher AMH. What would be the benefit of coming to the Zita West Clinic? Sorry, I made an error there. They are a same-sex couple, so it's sperm donor.
What would be, well, I'm presuming you've been using the sperm in IVF cycles, or have you been using them in simple insemination cycles? I don't know. If you've only got one ample, and how old is the lady, does she say?
She doesn't say how old she is, but, you know, very often same-sex couples don't have fertility issues. It's just a matter of getting the sperm, isn't it? Although she does have PCOS.
Well, we are very, very careful with the way we monitor. If we're doing IVF with PCOS, we can either do a simple insemination, but it sounds as if you've had several before. So it would be probably a good idea to do IVF. Make sure that you get as many fertilized eggs as possible. And then you'll have a very good chance of implantation from an embryo. A much higher success rate than IUI. The thing about IUI, if you've had, I don't know whether what's gone on in the past is IUI. If you've had IUI in the past and you don't get pregnant, we don't know much about, we don't know what to tell you. Was the egg released? Was it a mature egg? Did it fertilize? Did the fertilized egg divide and become a nice embryo? Did it actually get to the uterus? There are many unexplained things about why an IUI doesn't work, and we can't really tell you about them. Whereas IVF, at least you get over several of those hurdles in the laboratory. And then if we put an embryo in the uterus and you don't get pregnant, then we know we've pinpointed a problem there of implantation. But at least we'll know something about the quality of the eggs and the fertilization and that sort of thing. So I would recommend, if you've only got one ampoule left and that's all you're planning to do, then your best chance of success, and possibly more than one success, because you may be able to freeze embryos for future use as well, would be to do an IVF cycle.
Yeah. So, and we'd look at a holistic approach. So we'd look at her nutrition and acupuncture and hypnotherapy, etc., to do everything we could. So anyway, the best of luck with that. Okay, next question, Vivian. Would you suggest PGS, PGTA for a 40-year-old, and what other tests would Zita West Clinic offer?
Very much depends on the patient, but yes, for a 40-year-old, I would suggest PGS if you've got a good ovarian reserve, remembering that PGS doesn't increase your chance of having a baby. All it does is gets you there quicker and avoids a miscarriage if at all possible. So your eggs are what they are. By doing PGS, we can actually identify as quickly as possible the normal embryo, which will give you the same kind of pregnancy rate as a 30-year-old would if we find a normal embryo, and reduces your chance of either having a miscarriage or a pregnancy which may or may not go very well. So other than that, as a 40, we'd be doing our usual things: nutritional support and counseling, nutritional advice, acupuncture, which we recommend for everyone to help in blood flow to the uterus and the ovaries, and a very careful assessment of your ovaries and choosing a very personalized approach to the stimulation. That's what we'd recommend.
Yeah. Can you just explain to some of these ladies that are listening, what does PGTA
Pre-implantation
mean?
genetic testing, brackets, A means aneuploidy. So aneuploidy basically means an abnormal state of the chromosomes in the egg, which is there's nothing wrong with you. It's just as we get older, our eggs age as well, and some of them become abnormal in the configuration of the chromosomes, and they're no longer euploid, which is normal, they're aneuploid. So PGTA is basically genetic testing for testing the egg changes that happen due to maternal age, female age.
And who would this be? Who would be a candidate for this, and who
Well,
wouldn't
in
be a
general,
candidate
I would
for this?
recommend it to most women over the age of 37, 38, but also to women who've had repeated failed implantations or repeated miscarriages, because and changes in the egg genetics are by far the most common reason for early pregnancy loss or failed implantation.
Okay. There's another question here. Can IVF work if you have a short luteal phase?
Yes, absolutely. The short luteal phase, unless of course you can get someone to manage your short luteal phase first and get pregnant naturally. But yes, in IVF we hijack all of your cycle, and the short luteal phase doesn't exist in IVF because we add progesterone. We're going to be supporting the second half of the cycle. So yes, it does work, but you might not need IVF. It could be that you could be managed with prolonging your luteal phase and giving you some progesterone so you don't have a short luteal phase.
But that's what's important as well, because not everybody needs IVF.
Exactly.
And I think that for so many women, they end up in a fertility clinic and the first thing you think about is IVF, when really they need a bit of thinking space, a bit of time, a bit of prep. And all of that's really, really important, not just sort of being a number and, dragged through. Somebody has, so and I think as well, it's important to realize that IVF does manipulate your cycle. So, it doesn't matter if your luteal phase is short. Yep. There are ways around it if need be. Yep. Brilliant. Okay. Any thoughts on endometrial PRP? I'm 44 years old, 2 failed IVFs, no male or female issues, and a good AMH.
I'm presuming by...
Can you just explain what the endometrial PRP is?
I'm presuming the PRP means Neupogen or something like this, but plasma and rich... platelet-rich plasma is PRP, and you can either inject it into the ovaries, and I'm presuming she's had it injected into the uterus, or is thinking about doing that. I have no direct experience of that. However, what I'd like to know is, were the embryos that were transferred in the 2 IVF cycles she's had at the age of 44, were they tested? Because 95%, or I'd say 90% of the eggs of a 44-year-old woman will give rise to abnormal embryos that won't implant anyway. So it might have nothing to do with the endometrium. It might be all an embryo thing. And I wouldn't start looking around for reasons for failed implantation until I'd known that a euploid embryo had failed to implant. So PRP, if you've had 2 IVF cycles and failed IVF cycles at 44 with normal embryos, genetically tested normal embryos, then yes, start thinking about all the other things that might block implantation. I personally don't have much experience with PRP. I think it's something that's done mainly in Europe. I'm not sure whether it's available in London or not, unless you're talking about Neupogen, which is.
Okay. So can the contraceptive implant affect AMH in the long and short term?
That's the key question. I don't think nobody knows the answer.
It's hard, isn't it?
Because, we just don't have the studies. Who knows whether a woman of 38 who had an injectable implant for 15 years wasn't going to have a low AMH anyway. So it's a very difficult question to answer. Certainly taking the oral contraceptive pill, there are women who come along for an egg reserve assessment who are on the pill, and it seems to be a little bit low. And when they stop the pill for 2 or 3 months, it does improve. And there are other women in which it doesn't make any difference at all. So I think the whole question of whether or not your contraception is actually having effect on balance, I'd say it doesn't. Okay, your egg reserve is what it is. And in theory, by not ovulating and not having ovulatory cycles, then there are fewer eggs migrating towards the surface of the ovary, and possibly more being left in the reserve. Who knows? But I don't think anyone actually knows the answer to that. You can find as many papers on either side of the argument.
Another question which leads into that is a lady that's written in to say that what she's worried about doing IVF is it's using up the eggs in her reserve.
It's a similar sort of question. I don't think anybody knows. You know, every month a woman will have several eggs rise to the surface of the ovary and they get wasted, and that's why we run out of eggs. Whether or not towards the end, if a person is towards the end of their reproductive life and we stimulate the ovaries, we make it any worse, I don't think anybody knows the answer to that. There's no way of finding out. However, you know, what is the answer? Do I just say, oh, well, that might make my fertility worse, I won't do the IVF then? Or do you do it and have a baby? You know, your question is, am I going to try the IVF and possibly go into the menopause, or am I going to try and have a baby?
Yeah. What exercise should I do during my IVF cycle? Well, I know at the clinic we don't like women exercising when they're going through IVF. I think that it puts quite a strain on the body and can divert the blood flow. So I think it's good to do exercise, but gentle exercise. I don't know what your view is.
Yeah, I think going to the gym and that sort of thing is probably, you know, if you're one of these people who really is into exercise and you get your heart rate up, and as you say, it diverts blood flow to muscles. The gentle exercise like walking an extra block, you know, getting off the tube at a stop earlier and getting some is good. Exercise is good. Movement is good, because that will get circulation going and improve blood flow, as well as all the other things that we do. But severe exercise which leaves you short of breath, I'm not so sure is such a good thing, because that will, as you say, divert blood flow to the muscles away from the ovaries. But more walking, not a bad thing at all.
Yeah, but I think as well, for many women, when they're going through IVF, they do feel tired. They need to rest. You know, you can feel emotionally fragile sometimes, can't you? So, you know, not overdoing anything is important.
I've said that a lot of women really love going to the gym because it's a me thing. It's a treat. So go to the gym, but maybe do something gentle.
Okay, so the next lady here, I've been trying to conceive for 1 year. Nothing's happening. I'm 30. My other half is 41. We like to drink.
How much do you like to drink? That's the question.
Well, it doesn't say. And the thing is, yes, she's only 30, but she's been trying for a year, but it's hard to know what tests she's had done, whether she's ovulating, what her weight is. And, you know, what does we like a drink mean? I mean, so often in the clinic, people don't realize how much alcohol they are drinking during the week. So I think it's good if you can to cut back or cut down. But she's been trying for a year now, so she should go on to start.
If she's got regular cycles, I start with the simple, easy things like a sperm test, fairly early proceedings. And then maybe a test for her ovarian reserve. If she's got regular cycles. If she hasn't got regular cycles, that's a completely different thing. And it depends on her history. Has she had a history of an appendix operation or any surgery or anything like that? Is there a tubal problem? So there are some very logical, basic ways of investigating infertility. A year is long enough to wait, I think, at 30, before doing a couple of simple tests, which would, to my mind, include a sperm test, and if she's got regular cycles, maybe a test of her egg reserve. But you cut down on the alcohol. You don't have to stop drinking, but certainly don't get drunk. Certainly don't binge, and you know, have a small amount of alcohol if you feel like it. But cut back, definitely.
Okay. Question here is the IVF protocol different if you have endometriosis? And there's been a lot in the press the last few days on endometriosis.
It's not necessarily different. It depends. If it's quite severe endometriosis, there are some situations where endometriosis itself is an inflammatory condition. So there's inflammation around. And if there's active endometriosis going on, we wouldn't necessarily want to do IVF and transfer an embryo in a fresh cycle. We might want to create your embryos for you and then do something about the endometriosis to get the inflammation down before doing an embryo transfer. That's one way of looking at it. In terms of surgery, in general, we'd rather not operate because you cannot, it's very difficult to get endometriosis out of ovaries without taking away a good number of eggs at the same time. So surgery is to be avoided if at all possible. It very much depends on the degree of endometriosis and whether or not you can see a lot of normal ovarian tissue beside it. Nowadays, we do tend to leave endometriosis where it is, but if it's symptomatic and there's pain, there might be something to be said for creating embryos and storing them, and then treating the endometriosis so that the inflammation is reduced, which will give you a higher degree of implantation of an embryo.
Yeah. Okay. Thank you. I have a low AMH. I'm 32. It's 3.4. What sort of IVF should I have, natural or
Depends
mild?
how many follicles you've got. AMH in general tends to correlate quite well with the number of follicles, but if you need an antral follicle scan, to my knowledge of mild and natural modified IVF, 6 or more follicles, you could have mild IVF, and less than 6 follicles, I would do natural or natural modified IVF. So it does depend. The AMH is a clue. The AMH is a clue that there's something not quite right at your age, but the actual protocol you have will depend on the number of follicles that are seen on a scan.
Yeah, it's interesting as well because a lot of young women with AMH, there's a link to the thyroid as well. So maybe getting a thyroid
Well, I'm
check.
presuming you've had a thyroid check anyway by the around to doing AMHs and things. But yes,
yeah, but a lot haven't though. It's incredible how many haven't. Yeah. What can you do if you have had 5 blastocysts and 2 failed cycles when everything looked perfect? I was really shocked when my cycle didn't work.
How old were the embryos tested? No idea.
No, I don't know. That's she hasn't sort of said
so
that.
For example, if you've had, was it 2 rounds of IVF?
I've had 5 blastocysts and 2 rounds, 2 failed IVF
so it
cycles.
Could be, does that mean there were 3 transferred in one and 2 in the other? Difficult to know.
I don't know.
Again, I would say we need to test these blastocysts. The majority of the reasons for failed blastocyst implantation is genetic, and that is directly related to the age of the woman, and embryo testing would be the order of the day. But making blastocysts is the important thing. She's making blastocysts, and that's really encouraging. And she's making 2 to get 5 blastocysts in 2 cycles isn't bad. Okay, it's probable. It's quite probable. I mean, I saw a lady recently who had made 8 blastocysts and not a normal one among them, and she's going to go ahead and she will carry on until she finds a normal blastocyst because she's making blastocysts, and that's the encouraging thing.
I think it's so hard, isn't it, for women, because we do see women that everything is perfect and you sort of like think, right, it's going to work, and it doesn't. And that's what makes it difficult, isn't it? No matter how good the success rates are, there are women that it's not going to work for.
There are. And yes, that, I think before we get into what else could possibly be going on wrong, though, I'm as I say, the genetics of the egg and the embryo the egg makes are by far the most important thing, and it gets harder and harder as we get older, but it's still possible to get a normal embryo.
But the advances have been fantastic, haven't they, in terms of the testing, etc. So it really does give people a good chance. Question here, Vivian, I'm nearly 35 and I want to get pregnant with donor sperm. Should I get my eggs frozen now or just wait until I want to have a child?
So she right, I would get, if you're not ready to have a child now, I think 35 is a great age to start thinking about egg freezing, to be honest with you.
Because so often we see women that are 38, 39, 40 and their egg reserves are low, and hopefully the chances at 35 would be good. But it's important that you come along, you do a fertility assessment, which will give you an idea. And it doesn't mean to say you're freezing your egg straight away. It just gives you some time until you meet Mr. Nearly Good Enough or Mr. Right.
Nearly Good Enough. That's, I don't know what that is. But the lady said she was going to use donor sperm anyway.
Yes, yeah,
Because
yeah.
if she knows,
but that has its own
of course,
issues,
but if she
doesn't it?
says already she wants to use donor sperm and she doesn't want to have a baby yet, then she could freeze embryos with donor sperm. However,
Yeah, yeah,
she may change her mind and she might reach Mr. Nearly Good Enough, and then if she can't
yeah.
get pregnant
And then she's
with
got an
her
issue if
fresh
she...
eggs, she might say to him, "Oh, it's all right, I've got some in the freezer, but by the way, there with Mr. Even Less Good in the freezer." So, no. First thing, come along,
Yeah,
have a fertility assessment, and then we can calculate very
yeah,
easily how many rounds of egg freezing. You may only need one round to give yourself a really good chance, if you need it, and you need to use those frozen eggs in the future, of having a live birth from them.
yeah. I think as well, you know, what she could do is freeze her eggs, and then later on, if she meets somebody, great. But if not, those eggs are still frozen in time, and she can go down the frozen, the
Yeah.
donor sperm route
Yeah.
at a later date. So not to
Yeah.
make that decision too soon. But I think it's
The egg
important to have the implications counselling
Yeah.
around it, so you know
Yeah.
exactly what you're doing. Okay. What's my next question here? Do you do progesterone testing before you put embryos
Yes,
back?
we do. No, we do them at the same time. And then if the result, because you will have had progesterone after the egg collection up until for the 5 days until the embryo transfer. We went through a phase where we were actually not giving injectable progesterone until the day of the transfer, then testing the progesterone on the day of transfer and adding injectable progesterone to the pessaries if the level was low. And we found out that it's much simpler to add a little bit of an injection, not an intramuscular horrible IM progesterone injection, just a little subcutaneous injection to everybody. But we can test on the day of transfer to make sure that the progesterone is normal. And then when you have your pregnancy test, we check the progesterone again to make sure it stayed normal. So
So if it isn't normal, would you not put those embryos
no, we would
back? Would you put them back in the frozen cycle
and add more progesterone?
Yeah. Yeah. Okay. Okay. Great. Okay. What are your views on uterine tests? So obviously this lady is talking about ERA or some of the other tests that are around, Alice and can't remember the other one.
I think if I go back to what I said earlier, which was by far the most common cause of non-implantation, non-pregnancy after IVF comes from the embryo. And I wouldn't necessarily push for uterine tests before I've had, because most patients, if you transfer a normal embryo, you're good 70%, whatever your age is, 70% will get pregnant. If it doesn't work, I would then consider and recommend 2 tests. One of them would be to see whether there's any infection, subclinical, asymptomatic, chronic, long-term infection, or even inflammation, and they are different things. So if there's an infection, we can pick that up by doing an infection test, and then you'd have antibiotics. You and your partner would both have antibiotics. If there's not an active infection, but there's an inflammatory response as a result of a previous infection, we can treat that as well. Okay. And as far as the, and you see, it's all linked because there is a thing called an implantation window. So there are only about 4 days in the luteal phase after an egg collection when an embryo could, in theory, implant into the uterus. The receptors for the embryo appear and they disappear again about 4 days later. And within those 4 days, there is a day that is the best day to transfer an embryo. And usually it coincides with day 5 when you've got a blastocyst of day 5, but not always. In some women, it's actually delayed by a day or even 2, which is quite rare, or it's early, it's anticipated by a day or 2. Now, what the reason for that is, I don't know. It could be as a result of the previous things, as in chronic infection, a bit longer, the blood supply is not so good, the receptors haven't developed so quickly. And so there is a place for testing to see whether or not the ERA test would tell you whether or not you have a normal presumed maximum chance of implantation in terms of receptors. And if it's not the same as we're expecting, we can actually manipulate the cycle a little bit and transfer your embryos a little bit later or a little bit earlier, according to the result of the test. So these tests are quite sophisticated. I don't think they're standard screening tests at all. They don't need to be done for everybody. And by far, I think that the most important thing is to try and transfer a normal embryo. And if that doesn't work, then I'd start looking down these things as well.
Yeah. Okay. Fantastic. Well, we've come to the end of our time, Vivian. It's gone so quickly. Is there anything else you'd like to add or share with us?
Only pearls of wisdom. Oh, goodness me. No, it's just getting better and better. IVF is getting better and better. We've got this new thing arrived at Care and Zita West now, where we can actually, for any sperm issues, we can do a new test called SOS, which is testing for oxidative stress in sperm. And that will help us decide how much supplements the men can have. And then before long, we're going to have a test called Zymot, which is a fantastic thing. It's been available in Europe for some time. But if a man has poor morphology in the sperm, we can actually put the sperm through a tiny little horizontal maze. And if the sperm is able to find its way through the maze and out the other side, we reckon that's a good sperm. So that would be the sperm that's injected into the egg. So these are all, and the thing about IVF and fertility is everyone, it's so funny, everyone wants it to work. Everybody wants people to get, thank goodness, can you imagine working in an industry where you didn't want it to work well? Everybody wants everybody to have that baby. Yeah. And so the minute something new comes out, we think, oh, wow, this is going to be it. This is going to be it. So we're going to be, we do think about it beforehand, though. Not everything that comes on the scene is tried immediately.
Well, things go
and they come in and out of fashion. But that is the new thing that we're going to be offering, I think, within the next year.
And is that just a routine test that can be done as part of a workup?
Yeah. So if there's any sperm abnormality at all, we can send you for an SOS test. And that will help when it comes to the IVF.
Yeah, because again, it can help decide whether you do IVF or ICSI.
Yes, absolutely. And it also helps in terms of personalizing the nutritional support that the men would before IVF.
Yes. Yeah. Because I know there are other DNA fragmentation tests and everything, but sometimes they're very expensive, and if this is part of the routine, it'd be great.
So when's that available in some of the clinics now, but I think we'll be having it next week or the week after. Yeah. Okay.
Oh, brilliant. Brilliant. We'll have to do something on that as well, which would be great. Yeah. But thank you so much, Vivian, for coming along. Good. And we'll do it again soon.
Thank you very much.
Weeks, hopefully.
Okay. Bye.
Okay. Take care. Bye, Vivian. Bye. Bye. So next week, I'm going to be joined by Dr. George Ndukwe from the clinic, which is brilliant. And then one of our acupuncturists is going to join as well on Wednesday. So I'll be posting about that, but keep your questions coming. And thank you, everybody, for watching. Okay. Goodbye.